much, Laura, for introducing me. I want to going to share my screen. And what I would like to do is to give you some background on a number of studies we are running in order to know more about the nature of these spontaneous reports and also to improve signal detection. My name is Eugène van Puijenbroek. I'm a clinical pharmacologist, head of science and research at Pharmacovigilance Center of LAREP, and also professor of pharmacovigilance. And I'm very glad that also on behalf of my colleague Irea Waiting, who is carrying out the majority of these studies, I can give you some idea about the type and the nature of the studies we are conducting. Work package 2 actually focused on the primary data, so data intended for signal detection of pregnancy data and drug exposure. A subset of these studies actually focus on these spontaneous reports. So those are reports voluntarily reported by healthcare professionals and patients or consumers, you must say, to national pharmacovigilance centers and the marketing authorization holders. What I would like to do is briefly discuss with you two of these studies we're currently conducting. In the end, we want to to improve signal detection, but the first thing we'll have to do is we'll have to know something about the nature and the background of the data we currently are working with in respect to spontaneous reporting. So how important are these spontaneous reports? I think as Laura already mentioned, it has been a very important source of information in the past, and I think one of the let me see if I can. Yeah, one of the most well-known example, of course, is the example of thalidomide and the congenital malformations at the end of the 50s, beginning of the 60s. Although we collect a lot of spontaneous reports worldwide, we currently do not know what the exact nature and the quality of information is that's provided to us. And that, of course, is very important if we really want to use this source optimally. So in the first study we are carrying out in work package 2, demonstration study 1, is that we would like to get a better view on the nature and the content of spontaneous reports, and also literature data that are reported to the spontaneous reporting centers and pharmacovigilance centers worldwide. So basic questions like, do various data sources provide complete information? Do we have everything we really need to make a proper assessment? But also things like, what are the differences between the cases we have for the different reporters? Do healthcare professionals and consumers report the same type of information, or are there differences? And if so, what exactly do these differences entail? What type of information is missing? And in the end, of course, we want to know if we have a clear view on the nature and the content. We also would like to know how we can actually improve the quality of the reports in the future. So what we're doing in the first of our demonstration studies is we really want to dig into the nature and the quality of information provided in these reports. There are a lot of studies have been conducted for spontaneous reporting in general, but not as much as for spontaneous reporting for drug exposure during pregnancy. That's something that's really missing, and that's a gap we really want to dig into. So what does this study really add? We really want to describe the nature of the spontaneous reports related to drug use and pregnancy. So what kind of information do we have? What kind of reactions are reported? And what kind of information is present either in predefined fields or information present in the narrative. We also want to study the differences between the various types of reporters. And of course, we also want to identify which essential information is actually missing. And for that, we rely on some other information provided by the conception work package 2, and that is what we call the core data elements, key information we really consider to be present to make a proper assessment of the case. Just to give you a glimpse of what we have found so far, we studied almost 4,000 reports of healthcare professionals, more than 1,000 reports of consumers, and we looked into the presence or absence of those fields we really consider to be relevant. And without going into too much detail and without going into the numbers, just to give you some idea that, for instance, things like the mother date of birth is provided much more in reports from consumers, but also the start date of a specific drug is more often reported in reports from consumers, whereas healthcare professionals, for instance, mentioned much more often things like the last menstrual period, expected date of delivery, the stop date of a drug, and the exact timing of exposure in pregnancy. So there are differences between all those sources, and if we know those differences, we could also use this information to improve the lack of quality of one or the other source. So a study that is ongoing. It's clear that differences exist, and this is something we really would like to take a deeper look at. The second study is a tool to measure what we call the clinical quality. Of course, if we take a look at the report, we have information on specific fields, on the presence or absence of fields, and we already are looking into the nature and the completeness of the data, but it's much more difficult to get an impression about the information that's provided, for instance, in the narrative of such a report. Is the information provided sufficient to make a proper assessment, for instance, in respect to the causal relationship? So what we would like to do is we are busy developing a dedicated instrument for measuring this, what we call clinical information. So clinical information is that information that we need to make a proper assessment of the case in terms of causality or whatsoever. And that's information that's very often hidden in the narrative, and it's much more difficult to measure just based on the completeness or absence of information. So we're developing a tool, but we are also we would like to validate the tool and to test the tool, so to have a validated instrument. So what's the approach we took? The first step is that we have decided on relevant parameters to take into account. The second step we took is that based on these parameters, we compared the assessment based on the parameters versus the assessment based by expert as the gold standard. So people who are very familiar with these topics in fact assessed a number of cases for us. And we also use the instrument we developed to make our own assessment. And what we actually are doing is comparing the performance of this instrument versus the expert opinion. And we did that by doing a separate validation and testing phase using 60 randomized cases each. So actually, the idea is to come to a validated instrument. Just to give you an example, just to give you an impression, I'm sorry. about what this tool actually looks like. What you see over here are groups of information in respect to the ADR, in respect to exposure, in respect to potential risk factors to the child, and in respect to pregnancy and delivery. And we identified certain amounts of information that we consider to be relevant. It must be noted, however, that these are potential parameters of clinical qualities. So it's not the case that every element actually plays a role in a specific case. Information in respect to a case related to an early miscarriage is, of course, a different ball game as compared to the assessment of a case with a major congenital malformation. So the basic, one of the basic characteristics of this tool is that we only take those parameters into account which can be considered relevant. Like I said, this tool is currently validated and tested. Having this validated tool, the next step will be that we actually are going to use this tool to compare various primary data collections to measure the quality in more detail. So we do not only have an impression about the presence or absence of information, but also about the quality itself for assessment. And these studies will start over the next weeks. So hopefully within a few months, we will be able to give a much more detailed information about whether or not the actual clinical quality of these primary data collections are. So just to give you an impression of two studies, which we currently already finalized in work package 2, the first demonstration studies. We are going to work on the actual comparison of various data collections. And in the future, we will also work on studies into the signal detection. But so far, this is what we have done at this stage. Well, I think it's time now to pose you some questions on what your opinion is.